I really appreciate the invitation. It's always such an honor to get a chance to speak to everyone here at the Seattle Scientific Foundation. I am the chief of spine radiosurgery at Yale, and want to discuss briefly today about how I approach radiosurgery for spine metastases, but also discuss a little bit about how we built our program, what are some of the really key figures that we look at to really have a high quality growing program. We'll start with a quick case. This is a 70-year-old with metastatic prostate cancer. Had localized disease about 7 years ago, had surgery, prostate surgery. And did not have any additional treatments until 3 years ago. Needed some salvage radiation along with androgen deprivation therapy for biochemical recurrence. And now presented to see me. PSA was rising to 1, concerning with disease recurrence. And then on staging imaging, there was just only 2 sites of disease on the PET scan. 1 lesion in L1, another in the sacrum. And so we discussed with the patient different options. The traditional approach in this case with now metastatic disease would be indefinite lifelong androgen deprivation therapy. But that's certainly associated with a lot of toxicities. Anyway, anything from fatigue, weight gain, cardiovascular issues, fatigue, and just the fact that the quality of life can be dramatically reduced. Patient wished to really delay or not have ADT, the androgen deprivation therapy, as long as possible. And so we ultimately elected to just use radiation, specifically ablative radiosurgery, targeting both lesions. We treated L1, 30 gray in 3 fractions. We reduced the dose slightly to S1, 27 in 3 fractions with the sacral plexus nearby. And it was fantastic. Patient did not get any other treatments. We saw that the PSA, this really sensitive blood biomarker for prostate cancer, actually became undetectable about 8 months later. And now it's been about 2.5 years. The patient still has not needed any additional treatments for the prostate cancer. And it also, very importantly, the patient has no late toxicities from the radiation. There was no compression fracture, there's no plexopathy, there was no other neurologic issues from the radiation. And so this is clearly a very successful outcome. But I think it just goes to show you the ability for radiosurgery to sometimes be the best tool for patients. It can absolutely, for these patients where otherwise they would need either chemotherapy or systemic therapy with all the other toxicities involved, radiosurgery can absolutely really improve quality of life. With the radiosurgery program, really there's a lot of people involved. Certainly spine neurosurgery, I speak with Dr. Mendel all the time for patients. We need really high quality radiology, interventional radiology. When we do especially myelograms for some of our patients, especially in the post-operative setting where we have a lot of artifact with titanium instrumentation nearby. We need, with radiation oncology, a lot of expertise with the treatment planning and delivery. And so you may know with radiation oncology, we have certainly physicists, therapists, dosimetrists, amongst other specialists within just normal radiation treatment planning, but they should absolutely have some level of expertise and experience with spine radiosurgery. And certainly after delivery, there's importance for continued follow-up, both in terms of toxicity, potentially management of those, as well as a lot of these patients with metastatic disease, oligometastatic disease, they're at high risk for additional metastases, and we can reevaluate whether they benefit from further radiation or radiosurgery to the same or different sites. What patients need or different parties need with a good, high-quality radiosurgery program. The patients come to us and they need to be aware of why we're doing radiosurgery, what are some of the special risks, and what are the alternatives. I think the idea here is that we have conventional, traditional radiations for spine mets. It's lower dose, it's relatively easy to set up, it can be quickly delivered. In some ways, it's a bread and butter for almost every radiation oncologist, just run-of-the-mill, standard low-dose radiation for spine mets. And that is always an alternative in some ways for patients. But that said, the onus is on us as specialists to say why we think radiosurgery makes sense with the dose escalation, how it may benefit the patients, what they would experience going through that, and what are some of the additional risks with radiosurgery. What I need and my team needs, we really require this multidisciplinary approach before we actually embark on the treatment. It's deciding with the spine surgeons, do the patients have the spine stable enough for high dose radiation? Does instrumentation, is it needed? If we have significant epidural disease, do we need some kind of separation surgery before the radiosurgery? We need high quality imaging review, radiology, and sometimes, yeah, we need myelograms, we need interventional radiology, we need, and then certainly within our department, we need those expertise like mentioned, physicists, dosimetrists, radiation therapists. I would say from the medical oncology standpoint, what they really need to be aware of radiosurgery. They need to be aware of how we can benefit patients. So cases like I mentioned, that's so critical to really share with medical oncologists that may not be aware that, hey, we can use high dose radiation sometimes in select cases instead of other treatments to really improve patients' quality of life. And they really do want in a treatment, though, that does not significantly affect their systemic options. So in the same way, I'm sure when you guys are talking to a medical oncologist about the option of spine surgery and how that may delay or affect the systemic therapy options, it's similar with radiosurgery. The planning takes a little bit longer than conventional radiation. There isn't necessarily the same level of recovery, but the planning, well, a lot of times it may affect or kind of delay when they can get back on systemic therapies. Some systemic therapies we do not want to be at the same time as radiation. All those things are very critical. Some of these patients with metastatic disease, they're on a critical protocol, clinical trial, they're being considered for one, and the radiation can sometimes delay the consideration for that. So all these things we talk to medical oncologists in advance, and we really share their concerns. And those are the situations where when the medical oncologists have faith in our program, they're able to get patients back to our program in the outpatient setting. Fundamentally, why radiosurgery? We give more radiation dose to tumor in the spine. And it's somewhere between 2 to 6 times as much dose as conventional radiation, really the straightforward planning. Conventional radiation delivers a somewhat even dose of radiation to the spinal cord and to the tumors near the spine. But with spine radiosurgery, we're able to use really modern radiation planning techniques. In part, it's intensely modulated radiation with modern computer planning, what we call reverse planning, where we tell the computer where we need the radiation to go, where we need to spare radiation, and let the computer come up with different ways of trying to achieve that goal. So we can really shape and modify doses of radiation much more than we can with conventional radiation or radiation that we had only 15, 20 years ago. With radiosurgery, we then further enhance the IMRT planning by limiting the number of fractions and really having much higher doses of per fraction of treatment. So kind of analogy here with traditional conventional radiation, even for spine, we're giving kind of low doses every day, maybe to a large area over 1 or 2 weeks or even longer. With radiosurgery, we're giving high doses, usually between 1 to 5 sessions, usually between 2 to 5 sessions. Example of conventional radiation, again, this is the dose map. It's a very even dose. We're giving the same dose to the spinal canal as we are to the tumor. Okay, so we are absolutely limited by how much radiation dose we can give with conventional radiation by the spinal cord or the cauda nearby. But sometimes with conventional radiation, especially certain histologies, the tumors can absolutely recur. So this was a case where this was a renal cell carcinoma. There was tumor here in L5. We gave the patient conventional radiation because there was still too much tumor near the spinal canal, and just 8 months later, there was significant tumor recurrence. Similarly, with conventional radiation, the pain relief, we estimate anywhere between 60 to 70%, but it's generally not optimal for a lot of patients, and we are always thinking about how we can have better pain relief with radiation. Example of spine radiosurgery plan. We can really carefully carve the dose around the spinal cord. This is full dose, and this is much, much lower dose of radiation around the spine. This is just very technical data. Within a couple millimeters, you have really drastic drop off in the radiation dose, and that's very unique. Most conventional radiation plans are not like that. The onus is on us to really share some of the data that we have, the highest quality data that we have for spine radiosurgery. This is a randomized trial done by the Canadian group where they actually randomized patients between spine radiosurgery and conventional radiation. And they were able to see that the 3-month complete pain response and the 6-month pain response was significantly better with radiosurgery compared to conventional radiation. Notably, at 6 months, it was 32% complete pain response compared to 16% complete pain response with external beam radiation. This trial notably was not just oligometastatic disease. It wasn't just one or two brain or spine mets. The patients could have had however many spine mets. There was multiple histologies, so not just limited to the radio-resistant histologies like renal cell or sarcoma. They included lung cancer, breast cancer, some of the histologies that we consider to be relatively radio-sensitive. Notably, toxicity from this trial was really excellent. So we can see they randomized over 200 patients between conventional and radiosurgery. Basically, very limited grade 4 toxicity, only one case, and that was in conventional radiation. And even within this radiosurgery, there's only one case of grade 3 compression fracture risk. So a lot of medical oncologists, they're not aware of some of these really specialized spine radiation data. And so we've been really working hard to try to share this information with the medical oncologists to say this is really a great option potentially. When we select for patients, so some of the slam dunk indications for radiosurgery, if had radiation already, the tumor's regrown, we generally think we need a higher dose of radiation, right? If the normal dose couldn't control, we need a higher dose of radiation, and because the spinal cord has had some radiation dose already, we need a way to deliver a much more careful radiation plan. So usually spine re-irradiation, unless the patient is near hospice, has just a couple months of survival expected, we do consider radiosurgery. We really strongly think about radiosurgery with some of these histologies like sarcomas and melanomas, renal cells, where we think that with conventional radiation, the chance of control is very poor. Similarly, some of the complicated spine tumors, even if it's breast cancer, lung cancer, if there's really drastic extra vertebral body disease in the muscle, these patients are clearly known to have much lower chances of control with just conventional radiation. With patients where they have oligometastatic disease, 1 or 2 or 3 sites of metastases in the body, even if they're not symptomatic, we will consider radiosurgery for these. Usually for these, we would want to target all the sites. That's where it would make the most kind of logical sense. And similarly, these patients should have really good prognosis, usually at least 6 to 12 months of survival. A lot of the times, these are young patients, kind of new de novo diagnosis of oligometastatic disease, and absolutely, we'll strongly consider radiosurgery. Important inclusion criteria: recent radiation. We absolutely do not think that the spinal cord, the major nerves, are able to forget radiation. And so if it's been relatively recent, sometimes it's difficult to distinguish whether it's truly tumor recurring after recent radiation versus treatment effects. Obviously, STIN score we talked about, I'm sure today, instability, especially with radiosurgery, having a higher risk potentially of further compression fractures. Some of these patients with instability absolutely need to have stabilization before radiosurgery. We consider other things as well. Certainly, if the patients can't hold still for treatment, most of these treatments, the patients are on the treatment table for anywhere between 15 to even 30 minutes per fraction. And if there's too much pain, discomfort, anxiety, these are things that we have to consider or certainly try to treat beforehand. And obviously, just poor performance status. Examples of mass type, I think, that I mentioned. A lot of times medical oncologists may not know. They may say, oh, they look at a scan, it's, just metastases involving the vertebral body extending to the paraspinal muscles. They may just ask for conventional radiation, or they, without symptoms, may just say, let's continue systemic therapy. And so these are some of the differences that we routinely communicate to potential referrings. A lot of our patients will have separation surgery of epidural disease before radiosurgery. And very intuitively, we have great data. The amount of leftover epidural disease is what's most important predictor for local control after radiosurgery. And then the idea here is, again, very intuitive. We absolutely have to push dose away from the post-operative cord. That is always going to be really the most important factor for our plans. So a lot of times our radiosurgery plans, we're going to keep the space around the spinal cord a little bit cooler, a little bit lower dose than what we actually intend for the tumor ideally. And so if there's tumor left over in that space, that's a very high risk area for tumor recurrence. And so, if there's distance away from the cord, we think we can give extra dose. We can even boost doses to say 28 gray or higher in 2 fractions to tumors within the vertebral body. But it's really that space right by the spinal cord. We have to be extremely careful from the radiation standpoint. And just example, the amount of epidural clearance based on the postoperative Bilski, a really good predictor for local control. Some of the expertise, it's equipment, it's staffing examples. We really need good, what we call immobilization to keep patients both in terms of during treatment and between treatments in the same positioning. We would have routine this anterior immobilization, which is very unique for spine radiosurgery. A lot of radiation treatments in general around the body will already have this vacuum bag that patients lay on top of to really shape their back of their bodies. But we absolutely do think for the highest doses of spine radiosurgery, this anterior immobilization is also very important. For tumors in the cervical spine, upper thoracic spine, some of our tightest masks over the head and the neck really keep patients from moving between and in the middle of treatment. The radiation machine for the spine radiosurgery is also special. We will always have some level of imaging in the middle of treatments. So if the machine is on delivering radiation in each what we call arc, if it's on for 2-3 minutes, we're going to, in the middle of that treatment, have real-time monitoring of the patient's positioning. So it gives us the ability in the middle of treatment to even pause and adjust if we need to. Now, thankfully, most of the times, it's very rare that we have to adjust because patients both keep still from just their own kind of motivation, but also the devices we mentioned. But some of these tools are very critical. With spine radiosurgery compared to most other radiation treatments, we use some of the smallest, what we call margins, buffers for movement. And so we really go to full lengths to really try to minimize patient movement in the middle of treatment. Running out of time. This is actually a trial, another randomized trial published a couple years ago, comparing conventional radiation and spine radiosurgery. And they actually did not see a significant difference in pain response. Okay, and so after this trial, there's a little bit loss of momentum with spine radiosurgery in all comers with metastases, spine metastases. But I think it goes to show even more so. I think the point that we're trying to make. Looking back at some of the plans that were done for spine radiosurgery, there were questions about the quality of the plans. There were questions about the experience on the centers. Basically, they opened the trials, and a lot of centers maybe who don't have as much experience with radiosurgery were involved in the trial. And so that's one of the common questions about the results of the trial. Is the reason why the pain relief not better with the radiosurgery, despite giving more dose of radiation, is it because just the fact that the quality of the plans may not be at the same level as the high volume centers? This is just hypothesis, but I absolutely think for spine radiosurgery, having a lot of expertise, confidence, and not just radiation within radiation oncology, but within all of the other specialists, just so critical. I think with that, we'll get to the end of the talk. Spine radiosurgery absolutely can have really high rates of pain control, and with evidence that there's better complete pain relief for metastases than conventional radiation, as well as solid local control, but really require this technical expertise along with patient selection. And really the high quality radiosurgery programs require, as we mentioned, really great awareness on the part of referrings. Some of that certainly is the inpatient, and they come to find spine teams and radiation teams, but a lot of that, it's outpatient. It is the medical oncologist who realize that, hey, with radiosurgery, we can have better pain relief. We can quickly get patients back on systemic therapy. We can sometimes get the radiation instead of systemic therapy, and that will motivate the referrings to continue to refer patients to the program. And with that, I think I'll end there.
Thank you. Yeah, appreciate it. Thank you again. Yeah, appreciate your collegiality and the ability with you to build a really robust spinal radiosurgery program, which is absolutely key to what we do. I mean, sometimes, there's a lot of interest in this separation surgery. It's been discussed here a lot. but it cannot be done without having the options of doing radiosurgery. Ultimately, the total control is achieved with that and not with what we do. Just one question from my point of view. How do you console patients when it comes to potential iatrogenic spinal fractures after radiosurgery?
Yeah, it's a great question, and certainly it's something that both of us together, when we share most of these patients, will discuss. Generally, we have data, right, high quality data, that there's going to be a risk of compression fractures anywhere between 10 to 30%, but it's a spectrum. Sometimes it could be minimal and asymptomatic. And so it's really for the patients where it's symptomatic. Clearly, there's no active disease. Those are the ones that we talk about. We still have plenty of tools available that can certainly help with the fractures. And I always say, as much as we sometimes have to deal with the toxicities in terms of compression fracture, the toughest toxicity is tumor that is active in and around the spine. That's the hardest treatment to have.
Absolutely. Anybody have any other questions, Jan?
Yeah, as always. I don't want to be in front of Dr. Kolb here. Thank you for doing this again, Dr. Ahn. You're wonderful and great graphics, great didactic clarity. Appreciate that. Here's the question. So how sick do patients get from your current state-of-the-art radiation therapy to the spine? Do they take a physiologic insult? Does their nutrition go down? Do they have exhaustion? What's the physiologic impact of spine radiation in your experience?
Appreciate Dr. Chapman. So most patients do very well. I would say a lot of patients, more than 50%, mild fatigue for a couple days, a week, but nothing that we have to really do anything about aside from just waiting. Some patients may have a pain flare, acute pain flare. We do warn them about that. That's anywhere on the ballpark of 20 to 50%. Sometimes, if they can, it's just over-the-counter NSAIDs. A minority we will prescribe a Decadron just for a couple days. And every once in a while, depending on the location, we can have some mild esophagitis in the thoracic spine, where a week or two after radiation, maybe they have some swelling irritation. But the vast majority of patients, 1 month after radiation, the fatigue is gone. There's no pain flare. They're back to normal. That's 95% of my patients, if not more.
And then the second question, bone healing after a radiation therapy. Let's say we've done a spine instrumentation, we put some organ donor bone graft in there, and we wait for the obligatory 3 weeks until you start the irradiation. Is bone healing completely gone and out of question after you've been through with them, or is there still a chance for them to actually heal their, quote, fusion?
Yeah. Well, in my experience, we've absolutely still see healing. We see kind of evolution. We see sclerosis, long after radiation. So I don't by no means do I think it's black or white. Like after radiation, we have no further healing and whatnot. Obviously, at time of radiation, we do have to be very careful. We will always talk with the spine surgery team to make sure that the patients are adequately healed for radiation. So it's not black or white. Sometimes. As long as we have the clearance, as long as there's a kind of reasonable kind of decision there, we will absolutely proceed.